Okay, well, we will get started. So thank you everyone for joining us today. Our presentation today is on birth trauma, and this presentation is eligible for nursing continuing education, which is provided by SCL Health. We'll be providing you with a QR code following the presentation for you to redeem your certification. So make sure you stay till the end to get that CE. If you have any questions during the presentation, feel free to chat them in. And it will come to me, and then I can offer them to Dr. Shefferman. So our speaker today attended the University of Colorado in Fort Collins and received her PhD in counseling psychology. Since then, she has been practicing as a licensed psychologist with a focus on eating disorders, perinatal mood and anxiety disorders, infertility, birth trauma, and perinatal loss. Our presenter today currently works at UC Health Integrative Medicine Center, offering mindfulness-based interventions. Please help me give a warm welcome to Dr. Meredith Shefferman.
Great, thanks so much, and thanks for attending. Today I'm going to be talking about birth trauma and the impact of birth trauma on both patients and caregivers, with main focus on patients, but a little bit of information about caregivers as well. And I have a lot of information packed in these slides, so I hope to get through all of it, but also to leave time for questions and discussions so we can go ahead and get started. If I can figure out how to advance my slide. There we go. So what is birth trauma? The formal definition by Cheryl Titano Beck, who is one of the leading researchers in birth trauma, and she describes it as an event occurring during the labor and delivery process that involves actual or threatened serious injury or death to either the birthing parent or to the baby. And the birthing person experiences intense fear, helplessness, loss of control, or horror. So that is the formal definition. But what I will say, and what's most important, is that birth trauma truly is in the eye of the beholder. That what one person experiences at traumatic birth may not feel at all traumatic to another birthing person, and what might feel extremely traumatizing to a patient may not seem at all traumatizing to the provider. So it truly is in the eye of the beholder. I'm going to go through a list of some common triggers for birth trauma, but this list is certainly not exhaustive. So for some, it could be an emergency C-section. So baby is declining rapidly, and so they have to do a scheduled C-section. High levels of medical intervention, such as use of vacuum or forceps. Certainly if the baby has complications and needs to go to the NICU, or there's a separation from the baby, we know that NICU parents are much more predisposed to postpartum PTSD, as well as other perinatal mental health concerns like perinatal depression or postpartum anxiety. Severe physical complications or injuries related to pregnancy or childbirth, whether that's a severe postpartum hemorrhage or a perineal tear, like a 3rd or 4th degree tear, severe eclampsia or preeclampsia, unexpected hysterectomy. So really severe physical complications can result in traumatic birth. Prolonged labor or delivery. So individuals who labor for days and days and days, or, have to labor for a long time and then suddenly have to go in for a C-section, or for some, a very short and painful labor can be experienced as traumatic. Poor pain control, poor postnatal care. Certainly fetal demises have a much higher risk for postpartum PTSD, and then also birth of a baby with a disability that's resulting from the traumatic birth. And it's important to note that it's not only the birthing person who experiences birth trauma, but also the partners of the birthing person who witness the traumatic birth can also experience postpartum PTSD. And then there's also secondary traumatic stress in providers. So for delivery nurses, midwives, OBGYN are certainly, you know, possible can be traumatized by a difficult as well. Study showed that about 35% of labor and delivery nurses reported moderate to severe secondary traumatic stress, and about 26% of that sample met all diagnostic criteria for PTSD. So certainly this is not uncommon. So what are some of the attributes of a traumatic birth? So in qualitative studies, 5 themes consistently emerged throughout the research. So the first was the birthing person felt deprived of caring. So the women that I've worked with have described feeling abandoned or alone, or that the person, the labor and delivery nurse or the provider didn't care about me, felt like an assembly line. So really feeling like the person was alone in this and wasn't cared for. The second theme that has consistently emerged in the research is feeling stripped of dignity. So, for example, the person describing themselves feeling like they were on display for all to see, or felt degraded or disrespected. I've heard several of my patients, and this theme came up in the literature as well, describing it as feeling like they were raped on the delivery table. Related to that is a perceived loss of control. So feeling like they were powerless or helpless, um, described as my body no longer belonged to me. Um, Fourth major theme that I hear a lot in my medical work with patients is lack of communication. So things were happening fast, and there wasn't time perhaps to explain to the birthing person what was going on, or some people have described it as, the medical providers were all talking as if I wasn't even there. Like they were talking about my baby might die without even, communicating directly to me. Perceived invisibility during the labor and delivery process. And then the last theme, the literature by Beck refers to as buried and forgotten. So success was defined solely in terms of the outcome of the infant. So meaning that, oh, well, you had a healthy baby, so it couldn't have been a big deal. And a lot of the patients that I've worked with have shared that they often feel discounted when talking about their traumatic birth, because success is defined as far as, but you have a healthy baby and your baby lived and it's okay. So those are the kind of 5 main themes. And then as far as predictors for traumatic birth, the greatest predictor is previous trauma. So definitely childhood sexual abuse or history of sexual assault, domestic violence, or a previous traumatic birth. So individuals who have experienced previous trauma, and the more trauma you have, the more likely you are to develop uh, postpartum PTSD. We know that individuals with prenatal PTSD, so they already have PTSD while pregnant, are more than 3 times as likely to experience postpartum PTSD. And individuals who experience interpersonal violence or domestic violence twice as likely to experience PTSD from their birth. Also know that individuals who are suffering from perinatal depression, anxiety, so or antepartum depression and anxiety, are definitely much more likely to experience their births as traumatic. Research shows that lack of social support and low socioeconomic status, Pregnancy complications are predictive. We know also that individuals who struggled with infertility are more likely to experience postpartum depression, postpartum anxiety, as well as postpartum PTSD. Individuals who have had a prior pregnancy loss, and especially multiple losses, are more likely to experience birth trauma. And then the research is conflicting on individuals who are single, non-married when they're having their baby, and then age. Some studies have shown that younger birthing persons are more likely to experience birth trauma, but that's inconsistent in the literature. And then certainly as far as healthcare disparities in communities of color, we know, of course, that the lifetime prevalence of PTSD is significantly higher among Black populations than among white or Latinx populations. 13.4% of Black individuals experience PTSD versus 3.5% in non-African Americans. Latinx communities are also at risk of developing experiencing more persistent PTSD symptoms. And we know that people of color are definitely less likely to receive evidence-based treatments for PTSD. And since we know that prevalence of PTSD is higher among persons of color, that means that likely there's greater risk for postpartum PTSD as well, although there's less evidence. We know that if an individual has PTSD during pregnancy, they're more likely to experience postpartum PTSD. And so we know that up to 4 times as many pregnant women of color are experiencing PTSD during their pregnancies. So we can extrapolate from that to predict that they also have higher rates of postpartum PTSD. So how common is this? What can we expect? Research shows about 33 to 44% of women describe their births as traumatic. However, not all of those will go on to develop postpartum PTSD. And actually, the literature has a wide range of prevalence rates, anywhere from 1.25% experiencing postpartum PTSD, all the way up to 41.2% in one study. The prevalence of postpartum PTSD was in this study by Grecken and O'Hara in 2014, about 3.1% in community samples, but 15.7% in at-risk community samples. So at-risk meaning communities of color, individuals with, other mental health problems, pre-existing mental health problems, etc. And I'm not going to go through all of the diagnostic criteria for PTSD in the interest of time, but what we know is that in order to be diagnosed with PTSD, you have to either experience or directly witness a traumatic event. You would experience whether flashbacks, intrusive thoughts, nightmares, or dissociation. You have to experience at least one intrusion symptom. You have to experience at least one avoidance symptom, meaning avoiding thinking about your birth, avoiding talking about your birth, avoiding going to the doctor or the hospital where it happened. At least 2 negative cognition or mood symptoms. So whether that's feelings of guilt or shame or fault, loss of interest, feeling detached or estranged from others or from the baby, and persistent negative emotions. So whether that's sadness, anxiety, distress, irritability. And then you have to have at least 2 symptoms of hyperarousal. whether that's self-destructive behavior or irritability or anger outbursts. We often see hypervigilance in individuals with postpartum PTSD. So frequent checking on the baby, always, wanting to make sure that the baby is breathing, is okay. And that can certainly cause sleep disturbances as well. That, the parent can't sleep because they're constantly checking on the baby, or sometimes it's fear of going to sleep because nightmares are so persistent. You often see exaggerated start response, so jumping easily, and then concentration problems. And then these symptoms have to occur for at least 1 month in order to be classified as PTSD. And it has to, of course, be clinically significant. So what we know is that individuals who are experiencing significant stress and anxiety during pregnancy are more likely to experience preterm labor, to have poor infant outcomes, and their babies are more likely to have behavioral, cognitive, and interpersonal problems in early childhood. As far as individuals who experience a traumatic birth, we see often fears of subsequent birth or avoidance of getting pregnant again. Um, we see some strained parent-child bonding, so feeling like if the baby constantly reminds them of their traumatic birth, it's harder to develop that bond, or an anxious attachment is developed. We also see strained relationships with partners, whether that's sexual dysfunction, decreased emotional intimacy or closeness. You see increased fighting and increased communication difficulties. Birth trauma is also associated with breastfeeding difficulties. And then we also know that birth trauma is associated with maternal medical conditions such as hypertension, asthma, substance abuse, increased somatic symptoms such as GI distress, headaches, um, back pain, things like that. We see also increased risk for panic disorder and social phobia, and postpartum OCD, postpartum depression and anxiety. So pretty significant. And before I'm into prevention of birth trauma, because I feel like I'm flying through this and I can't see any of your pictures on the screen, but are any questions so far about what we've talked about as far as definitions of birth trauma, or risk factors for traumatic birth?
I don't see anything in the chat, but if you do have a question, you're welcome to put it in the question and answer box or raise your hand and I can unmute you for Dr. Shefferman.
Okay. So moving along to prevention of birth trauma. So the research shows that it's of vital importance for there to be extra staff training in perinatal trauma. So coming to workshops such as this, learning about trauma-informed care, and increased listening and communication skills. Um, Screening is probably one of the most important things that you can do to prevent birth trauma, since we know that individuals with a history of depression and anxiety and a history of trauma are more likely to experience their births as traumatic. It's really important during the antepartum time to do a good history of depression. I know a lot of clinics use the Edinburgh to assess depression, and that's great. To take a detailed trauma history, including prior birth experiences, history of sexual trauma in childhood, history of sexual assault and domestic violence, and to also get a good sense of the birthing person's social support, because we know that people with limited social support are more likely to experience their births as traumatic. And then individuals who do show some of these risk factors, benefit from enhanced preparation for birth. More time talking about what to expect during the birth process, psychoeducation about pain management, um, and to really work on coming up with a good birth plan. And certainly if you're seeing these individuals in your offices during pregnancy, to consider referral for treatment. Um, and I can certainly be a resource for that if anyone were to need help with finding treatment. And then PSI here in Colorado has great referral services and can get individuals connected with a perinatal mental health specialist. And as far as birth care, the research shows is helpful in preventing birth trauma, is really helping the birthing person to experience a sense of control, to be explaining, what's happening now, what's coming next, open communication when there's a problem or when, the treatment is going to change. And as much as possible, and I know this isn't always possible because sometimes things happen really quickly, but to try to involve the patient in as much of the decision making as possible. The greater sense of control a person has during labor, and the clearer the communication, the less likely that person is to experience a traumatic birth. Also, to really go over the birth plan with a patient. And sometimes, what the person has in the birth plan might not be realistic. And so going over what is realistic to expect um, can be really helpful. A lot of times, what I've seen in the patients that I've worked with birth trauma, that they have very, very, strong expectations of how they wanted their birth to go. They wanted an unmedicated birth. They wanted a water birth. They wanted to use um, their mindfulness tools or hypnobirthing, no drugs. They have a very clear vision of kind of what they want their birth to look like. And then if the birth veers outside of that specific plan, that can be experienced as traumatic. And so um, my colleague here at Integrative Medicine and I run a mindfulness during pregnancy group. And we talk a lot in the group about really trying to have a loose birth plan, kind of birth wishes, but to be open to, veering from that plan. And then certainly increased training of both providers and the patients in pain modification and pain management and comfort techniques can be helpful. Again, the greater of control a person has during her birth, the less likely she is to experience traumatic birth.
Dr.
Oh,
Shepherd,
and
there's
yes,
a
yes, yes.
question.
Great, please.
The question is, what about intended/wantedness of pregnancy? Is that a risk factor?
Mm,
I wonder about that as reproductive rights are removed.
excellent question. So I haven't seen anything about that specifically in the literature, but certainly clinically, I have seen that, that if a pregnancy was unplanned or unwanted, um, there's more likely for there to be depression or anxiety during the pregnancy. And so then, of course, that sets you up for greater risk of birth trauma, postpartum depression, and postpartum anxiety. So I think, yes, as Roe v. Wade has been repealed and there are going to be more unwanted pregnancies, I think we can absolutely see greater rates of postpartum PTSD, birth trauma, and perinatal mood and anxiety disorders. So great question, but I think it'll be interesting to see what the literature holds on that as we move forward in this time.
Great.
Any other questions?
I don't see any others right now, but I'll let you know.
Okay. All right, great. And this reference at the top, Vessel and Nakash, they had a really great, great list or resource for how labor and delivery providers can really help to prevent birth trauma. So I would highly recommend that resource. And then other ways to prevent birth trauma, we know that individuals who have greater social support, both during pregnancy and postpartum and in the birth itself, are, individuals who feel supported are less likely to experience their births as traumatic. So when possible, having doulas or other assistance during the birth can be helpful. Research shows that the more positive reinforcement a provider can offer to the birthing person, the less likely they are to experience traumatic birth. So, really saying, good job. I know this is hard, but you're doing great. Even at the end before the midwife or OBGYN leaves the room, to really, offer kind of positive reinforcement to the parent can be helpful. Certainly, we know breastfeeding support is very helpful because we know that breast chest feeding can be impaired by trauma. So, as much support as you can offer there. And also support both during pregnancy and postpartum can really help to prevent postpartum PTSD. So I include a link to PSI in here. They have just an incredible amount of support that they can offer both during pregnancy and postpartum. There's a peer mentor program where individuals can connect with other parents, chat with an expert. They have a very detailed therapist directory. There's the helpline, and then there's support groups for everything that you can imagine. Really impressive amount of support. So we encourage individuals to debrief after a traumatic birth. And the literature shows that it's helpful, although formal debriefing was not associated in several different studies with a significant decrease in PTSD symptoms. Clinically, what I've found with the patients I've worked with is that they do find it helpful to talk with their providers after the birth, just so that they can really get a sense of what happened. During a traumatic event, the brain doesn't work like it normally would. You're completely in the limbic system of your brain, the amygdala, you're in that fight or flight. And so this frontal part of your brain is kind of offline. And that's what's involved in being present in the moment. And so for a lot of these individuals, the birth feels very fuzzy. They either don't have clear memories or they can't, it feels all jumbled and out of order. So it can be helpful for the individual to talk to medical provider to hear their perspective on how the birth went, to kind of clarify any confusion. I think the most important thing about a debrief with the provider after a traumatic birth is really just leaving room for the patient to share their experience. Um, really trying not to focus just on the outcome of you had a healthy baby or but the baby's okay, but to really just truly listen to the person's experience, to acknowledge and validate their experience of the event, to listen and just provide respect and dignity. I think what I hear most commonly from patients is just, I didn't feel listened to. I didn't feel respected. I didn't feel understood. So I think that's probably, as a provider, the most helpful thing that you can offer. And then, of course, I know most OBs and midwives are already providing routine postpartum screening at the 4 or 6 week follow-up, but I think that can be really helpful. And then we know that the sooner you can get someone referred for support, the better the outcome. And so I know in our hospital here at UC Health, we have a special relationship with OBGYN and with midwifery, so that if there is a traumatic birth, there's a direct referral route to our clinic so that we can get these patients in within, a week or two of the traumatic experience. So we know that early detection and early treatment are beneficial. Questions about that?
There are two questions in the chat.
Right.
I'm not sure if they're directly related to what you were just discussing, but the first
Okay,
question
no problem.
Yeah. Do you have a sense of how likely people are to disclose prior trauma in screening? If there is avoidance, it may be hard to acknowledge.
Yes, absolutely. And that's true. You can't always, I mean, some individuals are very forthcoming about their history of trauma. Others are not at all comfortable sharing that. So the best thing you can do is just ask the question. And then, the more of a comfortable relationship you develop with the patient over time, maybe they'll be more likely to disclose. But if they don't disclose a history of trauma, but are showing some other depressive or anxiety symptoms, then certainly referral to a therapist at that time can be really helpful, and then the therapist can further assess history of trauma.
Yeah. And then the other question is, what about a client who had traumatic birth and then attempted a VBAC? Do you think it's harder if they had a failed VBAC or better not to try at all? Is this individualized? I had two clients recently in this situation, high postpartum depression and one who had a failed VBAC, as opposed to one who found out ahead of time vaginal birth was not possible.
Okay. So I am not familiar with any literature on this question, so I'm not going to speak from a research perspective, but clinically, what I would say is really providing as much information about risks and outcomes as possible, and trying to let the patient really be in control as much as possible a type of birth she would like to have. Again, the more sense of control, the better the outcome. So a person is really, really wanting a VBAC, then, to give them that opportunity, but with lots of information about risks of doing so and kind of what it would look like if, things aren't going well, and, that they might have to end up doing another C-section. Yeah, I hope I answered that question adequately.
Great, thank you.
Okay. So as far as treatment methods for birth trauma, cognitive behavioral therapy and EMDR are the two gold standards for PTSD. I will say that there is not a whole lot of research on postpartum PTSD specifically. That a lot of the research is more for general PTSD that we extrapolate to birth trauma as well. So with cognitive behavioral therapy, we really look at modifying some of the maladaptive beliefs, such as like, this was my fault, I caused it, I did something wrong. And then to also work on some of the behaviors that are keeping them stuck in PTSD. So helping decrease some of the avoidance and to increase more adaptive behaviors. This is the most studied intervention for PT in the general population, but again, only two small studies, the perinatal population, although those two small studies did show that CBT was effective in the treatment of postpartum PTSD. EMDR is eye movement desensitization and reprocessing. So this is a therapy that involves bilateral brain stimulation to help reprocess traumatic events and to be able to store them in more adaptive part of the brain. And this is one of the most advanced treatments for PTSD in the general population. And there are two studies, both showed effectiveness with postpartum PTSD. However, I will say that both of them had small sample sizes and weren't randomly controlled. And then, so I personally, this is what I often use to treat individuals who experienced a traumatic birth, and certainly I've had good outcomes with the patients I treat with this. We also know that treatments addressing insomnia can be really helpful. Insomnia is definitely a maintaining factor of PTSD at 2-year follow-up. And so helping with increasing sleep, whether it's, some sleep training with the baby, if it's the baby's sleep problems that are contributing to the parents' sleep difficulties, or for many, the nightmares from the trauma itself and the increased anxiety are contributing to insomnia. But we know that treating that insomnia can really help to decrease PTSD risk factors. So one intervention for that is called CBTI, cognitive behavioral therapy for insomnia. And there's an app called the CBTI Coach that can be really helpful for helping with sleep. We know that therapeutic journaling is really helpful both in general PTSD and in postpartum PTSD. What I will often have my patients do is to write out their birth story and read it out loud, both read it internally and out loud, and then also to have the patient's partner write out the birth story from their perspective and to read it out loud. So the reason for this is that we know that writing uses a different part of the brain than just talking or thinking about something internally. And so it helps the brain to be able to process it through in a different way. And so writing it out and then talking about it and then also hearing it can really help the person to process that birth story more completely. And then there's also research showing that having the partner involved in therapy is helpful for postpartum mental health. And then as far as other treatments for PTSD in general, and again, this is not well studied in the perinatal population, so a lot of this is extrapolation. um, I will use what's called EFT tapping. That's the emotional freedom technique, which involves it's self-applied acupressure, tapping on various acupressure points throughout the face and upper body. And there is good evidence to show that there are specific protocols with tapping that can be used to help PTSD. And then cognitive processing therapy is another evidence-based treatment for PTSD. But really what I mean, as birth providers, knowing the most important thing you can do is just to screen and get them referred to treatment as soon as possible. So I'm gonna go through a case presentation and then just open the floor for questions. And I know I've flown through a lot of information so far, so feel free to think of some additional questions. So I'm going to talk about a patient named Sarah. That is not her real name in order to protect her identity. She's a 29-year-old white cisgender female. She is married and has decent social support from parents and a couple of close friends. Her medical history is she has a history of chronic pelvic pain since adolescence, history of endometriosis. She was very, very fearful of becoming pregnant because of her history of pelvic pain. She was very mistrustful of the medical system. She's had a lot of negative experiences where doctors didn't believe her or thought she was maybe exaggerating her pain or would dismiss it. And so she had significant antepartum anxiety, and that's how she was referred to our Mindful Moms to Be group here at Integrative Medicine. And so we saw her in our group, and then I saw her for postpartum anxiety and postpartum PTSD. So her labor and delivery went pretty well until the end when she had retained placenta that they had to remove it manually, and her epidural had worn off. So she felt every bit of that. And she experienced that as extremely painful, extremely traumatizing. Um, and then she subsequently experienced a very severe postpartum hemorrhage. Um, she lost consciousness, had to have a blood transfusion. She doesn't remember the first 8 hours of her baby's life, which she has found extremely distressing. That she remembers when the baby was placed on her chest, but then she felt like she was going to pass out, and that's the last thing she remembered for about 8 hours. So she felt really guilty that she wasn't there to, welcome her baby in the way that she had wished to. She also um, felt like her provider didn't listen to her. Um, she felt like even though she was screaming in pain, the doctor didn't listen and kept going. She was really disturbed by the fact that her provider did not come back in to check in on her postpartum. So she didn't see that medical provider again. And so she had all of these holes in her memory. And then she felt like she had absolutely no control over her body. And of course, knowing that she already had a lot of mistrust of the medical system to begin with, and already had this, history of pelvic pain, and she had a lot of generalized anxiety um, before she was even pregnant. So these all kind of set the stages for this experience of trauma. Her PTSD symptoms included nightmares, flashbacks, feeling like she was back there in the delivery room. Um, she was very avoidant of going to the doctor, of going, to passing the hospital where it happened. She avoided getting treatment for her pelvic pain. And so to this day, she's still very fearful of having another child, isn't sure if she wants to have another child, even though she and her husband had always planned on having 2 or 3 children. So she had postpartum PTSD and then also postpartum anxiety and severe insomnia. As far as her postpartum anxiety, frequent checking of her newborn, um, she would not have her child with providers. She was obsessed about safety, and was on all these different infant safety listservs and Facebook groups, which then just reinforced all of her anxiety. So out of the work that we did, so we did EMDR, which definitely helped her PTSD symptoms. She stopped having the nightmares. She stopped having the flashbacks. We were able to get her to go back to a pelvic pain doctor. She still doesn't think she wants to have another baby, so that's certainly her choice. We use a lot of different mindfulness tools to help ground her in the present moment, and to help relax her nervous system. We've also done a lot of tapping to help calm her nervous system. We know that tapping is in research studies can reduce cortisol levels up to 42%. And so that's been a really helpful tool for her to calm down when she's getting really worked up. And then we've utilized a lot of CBT to help with some of the maladaptive thoughts that she had about this was my fault. I shouldn't have trusted this doctor, or I feel so guilty that the first 8 hours of my daughter's life I was not present. And so helping to alleviate some of that guilt, um, and to help decrease some of the avoidance symptoms has been helpful. I will say this patient's case was complicated by another traumatic event that happened about 6 months into our treatment. She was hit by a car, and so she had new PTSD symptoms from that. So It's definitely been up and down, but she's made a lot of headway as far as um, being able to go back to managing her pelvic pain, having less PTSD symptoms. So with that, I will open the floor to any question that you have or um, any comments.
Don't see any questions in the chat. Feel free to chat them in if you have any questions, or I'm happy to take you off mute if you have a direct question for Dr. Shefferman. Oh, there's one. Oh, it just says, thank you so much for your presentation.
Absolutely, my pleasure. And I've included my email address and phone number here. So if you have any questions, please feel free to reach out to me after the presentation.
Great. Well, if there's no more questions, thank you so much, Dr. Shefferman, for coming
My
today.
pleasure.
Your presentation was phenomenal, and I loved ending it with that patient story. I think that that's just really important and really grounds this information and reminds us that these are people and that it's not just a clinical story. So again, thank you so
Absolutely.
much, and I will reach out if there's any questions or if anyone reaches out to us.
Great.
But I will now share my screen for the CEs.
Great. Thanks so much for coming.
Hopefully everyone can see that. You can use that QR code to grab your CEs. And thank you all for attending today. We loved seeing everyone.
Thank you.
There's one just comment in the chat for you, Dr. Sharpman. It just says birth trauma
Oh,
can be
great.
really challenging for providers who are operating within a broken system that often doesn't prioritize patient autonomy. Let's keep trying to do better.
Great comment. It's so true. I know that our health system is not set up in the most helpful way to promote a lot of patient involvement, and it has to be very medicalized at some points. But I think just even awareness of the patient's experience and just opening those doors to communication is really vitally important and helpful.
Yeah, definitely.